So welcome everyone. It's really great to see people streaming in today. We had a lot of interest in this topic, which we started out really talking about because my friend Leah here, Leah Schust Myers, is the executive director of the FamilieSCN2A Foundation, and she has a son, Ben, who she will tell you more about in just a few minutes, about their recent diagnosis of ESES, CSWS. It's got a lot of names, but basically seizures and sleep, continuous, and some of the biggest challenges around that. Excuse me. We are also going to hear from Dr. Rob Stowe, Boston Children's. So he is clinical research and interests lie around this intersection of sleep and epilepsy and genetics. So he's really kind of you're the perfect match for this, Rob, right? So, so really looking at how sleep disorders influence seizure control and how epilepsy influences sleep. And I know we all struggle with that, which is incredibly challenging. And then finally, we'll hear from Carolyn McMicken, who is the Director of Clinical Development for Neurology and Rare Disease at Neurocrine Biosciences. We've been in touch back and forth talking with Neurocrine as well, because they actually have a clinical trial that's active looking at a treatment for ESES, which is there's not a lot of those. So we'll be really interested to hear about what that is. And if you're interested, how you can see if you qualify to be a part of the study. So without further ado, I am going to pass things off to Leah, and she's going to tell you a little bit about herself and her son, Ben, and about ESES. So I'm pulling up your slides, Leah. Mm-hmm. A second. I think we would have figured this out by now. Where is that?
Well, hello everyone, and happy Thursday. I truly appreciate you inviting me to tell our personal story here today. A little background on my family, as I think it's really important, as the spectrum for who's affected by ESES is pretty vast. My son Ben is 10 years old, and he had his first seizure at 13 months. He was diagnosed with a genetic condition called SCN2A a couple of years later. SCN2A related disorders cause a spectrum of disease, and it depends on the specific change in the gene, how you're going to present. So for my son, for Ben, it has caused autism, intellectual disability, epilepsy, and an array of other medical comorbidities. Ben is significantly impaired. He's nonverbal, he has low vision, he gets most of his nutrition and his hydration from a G-tube, and he's in diapers. He requires full-time care. But despite all of that, he is happy, smiley, and has always been a very easygoing and affectionate kid. When COVID hit, as most of you know, probably lived the very same life that we were, our world became very different very quickly. And Ben's world became very restricted and limited, and we noticed some really big changes in him. And there was like suddenly no school, no home nurses to help. We weren't going anywhere. We weren't having any visitors. And he was becoming increasingly more agitated as the days went by. He also started to lose skills, and he was regressing. It all seemed pretty reasonable to assume that it was due to the drastic disruptions in his routine because of COVID. Yet something just didn't sit right with me, and I felt that there was more going on. Ben started displaying behaviors that we'd never seen before. He was biting his hand to the point where we now have to keep a covering on it so he doesn't bite through his skin. He was banging his head and other self-injurious behaviors. He was getting so upset, and it got to the point that he was either raging and biting or he was crying most of the day, every day. And nothing we did to soothe him worked. and this became our daily ugly cycle. In addition to the behaviors and developmental regression, Ben's sleep became more disrupted than usual. I mean, he's always had kind of not that great of sleep, but it was worse than usual. He'd struggle to turn off and fall asleep, and then he was up several times every night for hours at a time. You may wonder, like, with a child like Ben, like, how can you tell what's going on? Like, if something's wrong, how can you tell if he can't talk and tell you? Well, that is when parents like me, and probably many of you, those that are listening in today, we take on the role of detective. So I knew something was wrong. I knew something was off, and I knew it was more than just COVID crazy. So I started by taking him to the pediatrician, who ruled out all the typical kid illness stuff like ear infection, strep throat. We did blood work. Everything was normal. And then we went to his GI and we did a series of tests that all came back normal too. And last, because of his age, we went to see an endocrinologist just to make sure that this possibly wasn't the beginning of puberty. And all the tests were, you guessed it, normal. Nothing was found that could be causing Ben to be so upset and agitated. I called our neurologist and we talked it through, and he said that usually, EEGs aren't really that helpful for Ben. He's epileptic. He's been epileptic since he was 1. He's pretty controlled with his seizures that I can see. So, it's not always a helpful thing to go in and get an EEG all the time. Plus, they're super stressful. But because we couldn't find anything else, he thought it might be worth doing an overnight EEG just to keep with the trend of ruling things out. So that is when we got the diagnosis of ESES. And Gabi, you can go to the next slide if you'd like. They said that 95% of his sleep was in continuous spike wave, and this could very well be the cause of all the symptoms Ben was displaying. We had an answer. We were very grateful to have an answer and a path to follow to get Ben some relief. I was happy that I listened to that little voice inside me saying that something wasn't right. And they started him on new meds right away, and we left full of hope that things were going to get better now. That was in November, and we have since tried and failed 4 treatments, and we have suffered through the serial EEGs that go along with this. It is exhausting, starting a new drug, titrating up to the therapeutic dose, failing it, and weaning off just to start all over again with another drug. Ben's ESES seems to be resistant to the currently available medications, and we are considering trying the ketogenic diet next. Throughout all of Ben's life, all of his diagnoses and struggles, I have to say that ESES is probably amongst the most stressful things we've had to deal with. The lack of sleep, the disappointment in failing meds, the behaviors, and the pure agony that we can see in our little boy every day, it's just torture for all of us as a family. This is definitely a tough diagnosis and one that needs more attention from researchers, clinicians, and pharmaceutical companies alike to get these kids the help they need. To all of you parents listening in today, you're not alone. I would love to connect with you, so please feel free to reach out. Thanks so much for listening to my story, and I'm happy to answer questions at the end of the presentation.
Thank you so much, Leah. And I'm sorry, I don't know why this didn't show well. So Rob, hopefully your slides will look better than I was able to put together here. But Leah, thank you so much. It's heart-wrenching, and I know it's so painful on top of all of the other stuff we deal with. So thanks for being with us and sharing your story.
I'm going to start next. Once I figure out, because of course, as soon as I try to do this.
I know Zoom has it out for us. I think Zoom is tired of Zooming and it's rebelling.
And this, and are we seeing a single screen? Just checking.
No, we see the double again for some reason.
Okay.
Even though we fixed this in prep.
Here we go.
There you go. You're good.
All right. So, hi everyone. I'm Rob Stowe. I'm a neurologist at Boston Children's. I did both sleep and epilepsy fellowships. So this is a condition that kind of falls right in that niche of those 2 disciplines. And I'm going to try and do my best here to talk about, I'm going to call it ESES. If you talk to other neurologists, you'll probably hear them call it ESES. ESES is maybe something I learned in my training at CHOP, Children's Hospital of Philadelphia. Frankly, when you say the word too many times, ESES is simply easier. So just bear with me, but I am talking about something called electrical status epilepticus in sleep. Just as a baseline, I do not have any relevant disclosures. And I'm going to try and do my best to define ESES and something called continuous spike in waves in sleep. Try to define some historical challenges to this diagnosis and those clinical consequences. A reasonable diagnostic workup when we do find ESES, and broadly describe treatment paradigms. And to Leah's testament, like there's a lot of challenges here. So I think the first thing is talking about the alphabet soup of these conditions. ESES, if you look it up online, you'll either see it be called electrical or electrographic status epilepticus in sleep. Sometimes you'll actually see it be called encephalopathy with status epilepticus during sleep. There was a paper in 2009 that argued stop using that term, call it frequent spike wave in sleep. There's also two defined clinical conditions, CSWS or continuous spike and wave during sleep. Sometimes, depending upon who you're reading, maybe they'll argue that's only during the slow wave sleep. There's also a sub condition called Landau-Kleffner syndrome. We're trying to not use eponyms. This is sometimes called acquired epileptic aphasia, where children have regression of their speech. Generally speaking, ESES is defined as more the EEG finding, whereas CSWS and LKS are more the clinical phenotypes. Of course, Leah introduced me to from the International League Against Epilepsy, a current, a proposal to update the definitions to developmental or epileptic encephalopathy with, I believe it's activation of spikes in sleep or something along those lines. And one of the arguments is to try and get rid of all of this alphabet soup, which I would greatly welcome, because I think us getting tied up in the alphabet soup leads to just more confusion than necessary. This is at least what the EEG may behave like. This is a patient that I saw in fellowship where the first half of this EEG, patient's awake and we see some of the background, but as soon as she falls asleep, it's like a light switch is turned on and it's just angry and active with lots of spikes. And this is ESES. And if we were to continue showing more and more of this EEG, we'd be seeing that it's just this robust activation of spikes. In terms of general clinical features, there are some parts that are rather well described, but I think our definition has historically been rather myopic and very closed. Often it is associated with epileptic seizures. The classic story is actually the seizures are under okay control, like a few here or there, but then there is this regression, and regression is such a subjective terminology, but often cognitive function. So whether there's a loss of language or aphasia, whether there's some increased motor impairments, whether they're ataxic and not able to walk as well, there's some dyspraxia, they kind of lose some of the finer skills, like they start stuttering. There's always this big question about autistic language aggression. There's gonna be some papers saying that such a presentation after the age of 3 might support ESES, whereas an autistic language aggression prior to the age of 3 is probably more a presentation of autism itself. The classic story again, ages 3 to 6 years old, funny developmental, not well understood phenotype that somewhere in that pre-adolescent pubertal brain change, this pattern kind of goes away. Some channels are probably turned off and some are turned on, and this doesn't really happen after that point. But it's just because it goes away doesn't mean we don't try to do something about it, because we do know that if the longer that pattern does exist, there is a higher likelihood of longer term poor neurodevelopmental outcomes. The kind of key clinical phenotypes of ESES, that continuous spike wave in sleep, this one is kind of more defined as a global regression, where there's aggression, a lot of behavioral challenges, ataxia. And these are often children who may have known preceding neurodevelopmental disorders, kind of like perhaps like SCN2A or abnormal brain MRIs, a child who had a hypoxic ischemic injury at or around birth. These can have actually rather severe seizures, and these are kids who, but it's one funny component is that we try to avoid lumping kids who have tonic seizures, because there's an important differentiation of Lennox-Gastaut syndrome, and because maybe that would open up an entirely different armamentarium, and we'll talk a little bit about why that's somewhat important. Landau-Kleffner, I've already somewhat addressed. Their MRIs tend to be normal. It's really this very peculiar, well-described language-specific regression. These are often, early school-age children who've had maybe 2 or 3 seizures, seem like this pretty well controlled, but there's definitely this regression in their speech specifically. One of the historical challenges of ESES is the definition. I mean, I already talked about the alphabet soup, and there's enough confusion there, but when we talk about, Leah brought up her son's spike wave index was 95%. And that's a case where someone would look at his EEG and no one would argue. And that goes back to this old paper 50 years ago. They described that the spike wave index in some patients, it was 85%. And that was essentially turned into the number you had to meet. But there's nothing, this was just a description of 6 children who were at the time institutionalized, had significant intellectual disability. And no one knew if 85% was a magic number. And there's been other papers and researchers who have argued maybe it could go as low as 25%, and perhaps more important, I won't say more importantly, but at least increasingly gain significance or appreciation is the idea that that number is probably 50%. So if you have a spike wave index, and I'll talk a little bit about what that means a little bit more, being 50% of your sleep has a spike, that might be enough to really say this is ESES and this might be something we need to tackle. It's also important, and this kind of goes what I was mentioning about the connotation of Lennox-Gastaut syndrome, is we want to also make sure that we are actually having activation of spikes in sleep. There are patients who have robust and very frequent epileptiform discharges in wakefulness. So really, if a child has a spike wave index in wakefulness greater than 50%, I don't think there's going to be very many neurologists who would feel comfortable making that diagnosis, because there are patients who do have some minor or modest activation of spikes in sleep, but we really want to try and approach this as cleanly as possible in patients who have a very active awake EEG and then have activation in sleep. Is that actually an entirely different process? I think this involves a conversation with your neurologist, as well as trying to tease in some of the clinical concerns that you may have. I'll bring up these slides just to argue that from my own experience working with some older physicians, there are perceptions and perspectives that may not necessarily they're not necessarily cohesive with what the literature states now. Some physicians will say, no, ESES has to be like this top EEG where the spikes are all over the place, they're diffuse. It looks very angry, and they won't count a patient who has very focal spikes that are very frequent, like the one on the lower. And that's, at least when we look at these recent papers, are really arguing it can look a lot of ways. It's really, I think, that spike wave index. This is a somewhat silly slide about calculating the spike wave index. I bring this up just because there's a lot of arguments about how do we even count, what does 85% spike wave index really mean? There are a lot of ways to count, which sounds very silly, but no EEG or EEG reading neurologist is going to read the entire night's sleep. It's what really tends to be the first 100 to 300 seconds, and there's pretty good fidelity that that little snippet in time is going to correlate to the rest of the night. There's automated detection software, but and this is probably the more frustrating side of that, there are some physicians who are not going to go through that process, and they just like, I know ESES when I see it, and there is no spike wave index necessary. It's just, yes, that looks like it, or that doesn't. And that's probably a bit of a disservice to these patients. And of course, this is something that I just presented a lot of this information to a grand rounds at NYU. And the thing is an important aspect is that even though I said the first 100 seconds or 300 seconds may be reasonable, there are some slightly different presentations. The first 5 minutes of sleep would catch patients who have that robust activation and light sleep or have it all the time, but it may not catch kids who really fall into this slow wave sleep pattern. So I think it's just to say that in any good neurologist and person who reads an EEG, they're looking at all of the EEG to kind of get this, but it's important to look at more than just that first 5 minutes of sleep. This is really the kind of like our best information, and it's like our only guideline. That really said that spike wave index should be 50%. If someone says 85%, they're not really following the guidelines anymore. And this paper also argued that, hey, it doesn't have to be diffuse and bilateral. It can be a lot of different presentations. And that's what frustrating. And this paper from 2013 really explained that there is a lot of variability within the field of neurology. So this is from 2013. That guideline paper was 2009, and more than of these 219 neurologists, half of them said that these conditions like ESES and CSWS were synonymous. About half of them said that 85% was the necessary cutoff. Really, the only good concordant information was that everyone agreed that this is something that occurs in childhood. That doesn't really speak really highly of what the field thinks of this condition, and probably speaks to the fact that it's been murky and not well defined and probably underlooked and undertreated. Leah did a really good job of describing a multitude of concerns that kind of led them down that path towards understanding and finding out ESES. But what's really challenging is that an increased sleep spike wave index doesn't have a specific or defined neuropsychological profile. Some kids, it's this, broadly global regression. That could be easy at something like very clear. My kid was talking in full sentences. Now it's 1-2 words, it's grunting. They've lost language. That's clear and obvious. But what if it turns into subtler things, stuttering or sleep disruption? That was actually a big phenotype for Leah's son, and yet that's not a well-defined component to this. There are a lot of well-described behavioral challenges and changes, aggression, just more behavioral disruption, like disruptive behaviors, and hyperactivity. It's there's a lot of ways that this can present, and there's not one like, oh, this to really hit the nail on the head, you have to have language regression and sleep problems and stuttering. It can be rather broad and diffuse. And I think if there are concerns that my child has either had stagnation of their development or loss of skills, an EEG is an EEG that captures sleep is going to be of very high value. I'll run through these parts because there are these peculiar instances where we capture ESES incidentally. And this is probably more so related to those patients. Any patient who has ESES should have a brain scan. There's actually very well described that children who have had early developmental injuries, often related to hypoxic ischemic encephalopathy, and particularly have had injured thalamus. Those are children who are a particular risk for ESES. In terms of the genetics of ESES, I think that's one that probably is, as the world of genetics as it's been exploding, that's something that we're doing a better job of. There are several really rather common and well-described causes of ESES. Probably the most common one here is this GRIN2A. This really kind of came to fruition back in like 2010 to 2013, and everyone was like, oh, we're going to get so many good answers and understand ESES for the first time. But GRIN2A probably only accounts for somewhere between 10 to 20% of all ESES cases, and as we probably broaden the definition and tighten the definition a little bit, that number may change. But frankly, if you look into the literature, and I'm not asking anyone to do so because I've done the painstaking effort to do so, I've listed off a couple different options. There's really no unifying genetic cause to ESES. It's more to say that there is some degree of epileptic dysfunction from an epileptic network, rather than like, oh, there is a specific gene that we can point our fingers at. And it may relate more to underlying neuronal dysfunction because congenital Zika has been well described. An important one that I think may relate for some patients and families is there are certain medications that might worsen spikes in sleep. Those often are sodium channel blockers, which turns into a rather interesting pickle for patients who may have like SCN2A, where our sodium channel blockers are the preferred treatments. And I think we don't have a clear understanding of that just yet, but certain medications have been described to have to worsen spikes in sleep. And if I was to see a patient who had developmental regression on one of these medications, one of my thoughts would be, I need to take that medication off and either replace it if they have active seizures and see, do things improve? And there's a big autoimmune hypothesis to ESES as well. And the reason that is because we start talking about effective treatments, and Leah's story as well harkens to this. There's many described treatments. Essentially, if it's been used for the treatment of epilepsy, it's been used to try and treat ESES. That can be, the most common ones tend to be steroids. Kind of that goes towards the idea, is there an autoimmune? Is there some immune dysfunction? Benzodiazepines are the other probably most common, but medications like valproic acid, levetiracetam, ketogenic diet, acetazolamide, it's a laundry list. And these are essentially nothing there's very little information that says one is clearly better than the other. The best information that we really do have is this paper from 2015 that suggested, after looking at 575 cases, that perhaps steroids and benzos had the best evidence for some degree of improvement. Of course, the number actually looks best for surgery, but as is the case for most neurosurgical procedures, it's very highly selected population. So it's the smallest population, and so it's rather cherry picked, if you will. Right now, at least from this paper in 2014, the typical treatment preferences of most neurologists tends to be benzodiazepines, steroids, seizure medications. Diazepam and clobazam are probably the two most commonly used benzodiazepines. Prednisone was the preferred steroid, but there's way too many steroid regimens that are out there that are described. And if you look at a paper, it'll say, yeah, this steroid regimen worked. One of the keys here is any of these treatments, whether you're talking about benzos or steroids, valproic acid, levetiracetam, even some support for IVIG. The evidence is not great for that, but there's some patients that do seem to improve with IVIG as well. These are things that you have to be on for a while. It's been kind of the hidden, somewhat of a hidden secret for ESES is that if you find a treatment that works, that the spike wave index finally does drop, you're probably going to have to be on that medication for 4-6 months. There are certain steroid regimens that are published, like the wean, because you have to kind of slowly wean off those medicines, up to 21 months, because it's whatever is causing this fire, this ESES brain on fire when you're asleep, we're trying to extinguish it and keep it out. And if you just try to let off, it's going to rise back up. There's not well-defined treatment success. If your spike wave index is 55%, which would be ESES, but you brought it down to 45%, do I think that'd probably be a treatment success or just the variability in night to night? It probably has to be more than that, but the likelihood of us going from, say, 95% to 0 is also going to be really tough. I think, of course, our primary goal is, do we really observe and see clinical improvement? That's going to be our goal. I mean, frankly, if the kid goes back to being themselves, even if the spike wave index is still high, I think we'd be much happier. The real challenge is there are patients who they have an elevated spike wave index and either have no discernible clinical changes, which is a big challenge. We have to really tease out the importance and the utility of exposing them to some more aggressive treatments, or the potential that your spike wave index does improve, but you really don't have any good or expected clinical change. That's another potential, and that might mean those behavioral changes or be late. And hopefully kind of got you to the other side with ESES phenotype index of greater than 50%. And it's a very highly.
I don't know if that was just me that things broke up for a minute there. But sorry, just the last point you made. Thanks.
About stopping treatment or?
Yeah, I think just your last statement there.
Okay. I think the challenge of knowing when to stop treatment is really challenging, and challenge of sometimes spike wave index improves, but you don't improve. Sometimes these aren't necessarily clearly, it's not necessarily a causal thing. And maybe, especially for children who may have underlying genetic diagnoses, is that something that might be an expectation of that specific genetic diagnosis? One of the conditions that I didn't talk about is something called, which is a known progressive, and devastating epilepsy. So if you're able to fix the ESES in that patient, but they still didn't get better, is that just because their underlying condition was just also going along as well? The key points, though, is that ESES is this EEG phenomenon with a spike activation in sleep of more than 50%. There's a highly varied, the descriptions of their clinical manifestations are highly varied. The classic description is there's some form of regression or developmental stagnation. Sometimes, and this is the really frustrating and confusing part, is when there's no clear clinical manifestations. We were just checking in because, my kid had a couple more seizures, and then we see ESES, but he's otherwise fine and still doing well and still engaging in his therapies. And how do you approach those patients? Treatments are highly varied. And there's not a whole lot of evidence that tells us exactly what regimen is best, although there are some trials that are undergoing that might give us some clues. It may be that benzodiazepines and steroids may be most helpful, but there's a lot of other treatments that have been described as having some benefit, and sometimes you need to do these multiple treatments in conjunction. And so I think being open to that possibility is appropriate. And perhaps the most important is partnering with your neurologist to discuss when you have a concern about your child, about their development, about changes to their behavior, asking them, do you think ESES, or perhaps what you may want to ask them is ESES something that we should consider, and do you think an overnight EEG could give us some information? And based on those findings, maybe that'll help you to define new goals of care or kind of tailor it for your child. And I have some references, but I look forward to talking with you all some more at the end of this talk. So thank you.
Thank you so much, Rob. That was really informative. And to end on a note with a little bit more hope, we're going to talk about a treatment that is in clinical trials right now. So Carolyn, welcome you to. Great. We don't hear you yet, though, if you are muted.
Okay, I'm sorry, I was double muted. Can you hear me now?
Yep, great.
Excellent. Well, first, I just want to start out by thanking Leah and Rob for setting me up so well. I'm learning along with everybody else, and I really appreciate both of your presentations. So today, I'm going to tell you about Neurocrine and an investigational treatment for CSWS. For those of you who are not familiar with Neurocrine, while we are somewhat new to the epilepsy space, Neurocrine's been around for 3 decades. And I just want to highlight that our passion and our commitment is to relieve patient suffering and to reimagine treatment and enhance lives. And for myself and my colleagues, this isn't just our job, it's our shared purpose, really. We want to change the course of conditions like CSWS and deliver on hope for our patients. Kind of bring you to all the programs that Neurocrine has right now. We have a robust pipeline that includes some commercially available products that you see on the top there, and then a portfolio of compounds in development across neurology, endocrinology, and psychiatry. So you'll notice some of them have names and others have numbers, and that's because they haven't received their generic names yet, but they are in development. So about our epilepsy pipeline. Our pipeline, we have multiple disease states, but within epilepsy specifically, we have 2 compounds. NBI-827104, which I'll speak more about today, is an investigational therapy in development for treatment of essential tremor and CSWS. And for both indications, we're currently enrolling in ongoing phase 2 trials to evaluate the safety and efficacy of these compounds. And this compound in particular was acquired from a company called Idorsia. And we also have NBI 921352 that many of you may also be familiar with. In particular, I know Gabi is. That's an investigational therapy, also getting ready to start trials later this year for the treatment of SCN2A DEE, as well as focal onset seizures in adults. And before I go on to tell you a little bit more about kind of why epilepsy and what we have going on in CSWS, I do want to kind of reiterate that we're committed to improving lives for patients, and we can't do that without really deepening our understanding of the impacts of conditions like CSWS. To that end, at the end of this presentation, I can share some information with you, but we are seeking to interview caregivers about, who have children with CSWS or ESES to understand better how the condition is impacting them. And I want to say a special thank you to Leah for partnering with us and helping, and maybe some of you have already responded to an ad that you saw online. So about epilepsy, I'm not going to go into describing epilepsy or CSWS because Rob did a great job of that. And I know many of you already have been in this world for quite some time. But again, it gets back to the significant unmet need that we recognize for children with rare epilepsy. And it's not just the seizures, right? It's all of the kind of the syndrome, the coexisting symptoms that go beyond seizures. So we recognize there's an urgency as well because of the higher risk of SUDEP in children like those with CSWS. Okay, so now I'm going to get into kind of, Rob talked a lot about the symptoms of ESES and what the EEG pattern looks like. I'm going to attempt to go a bit deeper than that, so bear with me. And we're going to talk about the proposed mechanism or kind of what we think is contributing to the development of that ESES pattern. And, first I'll start by that neurons, the nervous system, share as we think it's our thalamic oscillatory circuit. So that's a network of that connects brain that you see here. And the thalamus has direct connectivity to any parts of the brain. It's almost a gatekeeper or a relay station for information processing. And importantly, that this circuit is integral of sleep, which I believe is very important in the consolidation of memory and learning. So, more detailed here, the calcium ions are critically important to the function of our neurons. And they regulate function of neurons within this thalamic oscillatory 3.1, 3.2, 3.3 are T-type calcium channels. These are proteins that are expressed in the cell membrane, and they provide a passageway for calcium ions to go through. And this is foundational to creating the electrical signals that are used to communicate. It's also thought that even subtle changes or modifications, abnormalities in these calcium channels can really drastically affect function and play a role in the initiation of absence seizures. Further, ESES is thought to be caused by abnormal T-type calcium channels. Okay, so that's the basis for the development of our investigational compound, NBI 827-104. 827-104 is a novel orally available select T-type calcium channel inhibitor. So what that means is it's still under, we're still researching it. It's new. It's a medication that's taken by mouth, and it is selective for those T-type calcium channels that you saw in the previous slides. So in order for a medication to do its job, particularly for CNS disorders, it needs to be able to cross something called the blood-brain barrier. And this compound does that. It also selectively targets and blocks all three of the T-type calcium channels we believe are involved in EE-CSWS. And I'll take a pause here because I don't think we mentioned earlier, we have the distinction, another part of the alphabet soup of the EE, so that stands for epileptic encephalopathy, and just kind of signifies the changes in cognition that are associated with CSWS. Importantly also, this compound has the potential to be used in combination with the other established anti-seizure medications that would currently be used for patients with CSWS. So we are initiating, or we have a phase 2 study that is enrolling, and it's called the Steamboat Study. The purpose is to evaluate the safety and efficacy of NBI 827-104 in children with EE-CSWS. We're enrolling children ages 4 to 12 years old. They must be on a stable dose of 1 to 2 anti-seizure medications and have no other relevant neurological or seizure disorders. And within this study, the participants will be randomly placed into one of two groups, either the treatment group, which they will get the investigational therapy, or the placebo group, which will receive an inactive drug. And for this study, we are evaluating the ESES EEG pattern of participants using EEG and video recordings during the first hour of non-rapid or non-REM sleep. So I know this was a very high-level overview, but the phase 2 study, like I said, is currently enrolling. We have a website you can visit, www.stillwaterprogram.com, and on there you can click to see who may qualify. You can also go to our company website, neurocrine.com, to learn more about our pipeline, including this program in EE-CSWS. And I think
Thank you so much, Carolyn. That's terrific. So I'm gonna ask everybody to come back on, Rob and Leah. We've got, and me too. There I am. All right, so we have a lot of questions, which is great. Hopefully we can clarify a number of things. But to start with, we have a couple of people who are writing in that they had preemies and that there was brain damage, and trying to get a better sense of what brain damage is happening due to premature birth and what's actually happening because of ESES. I don't know if you have thoughts on that, Dr. Stowe.
Yeah, it's a really good question. Is that there has been some recent papers just published in this past year that have argued that children who specifically have had known thalamic injury in the perinatal period, that perhaps sequential EEGs might help to predict the risk for ESES. But I think it's one of the challenges of hypoxic ischemic injury or perinatal injuries, especially in premature infants, is that our initial MRIs are not terribly sensitive. There's a lot of water content in the brain, and it takes time to really get a good, clear picture. So sometimes we may not really see all of the great detail of that we might see in an older child. And that's why it's not uncommon for patients to get another MRI sometime at around 3 years old to kind of get a better sense of things. But there is a possibility that subtle, and the other challenge is that the MRI is really good at seeing kind of macro structural, like things that we can see with our eyes, but is there the possibility of subtle microstructural injury that doesn't really come out? Possibility.
Great, yeah, and I think there were some questions that came up as well about recommendations around neurofeedback therapy or any other kinds of therapies that are emerging, coming up. I don't know what kind of evidence there is, but yeah.
I can't say that I'm familiar with any active research or evidence towards specific biofeedback, neurofeedback therapies for ESES. I mean, I think there's a lot of very fascinating newer work in things like transcranial magnetic stimulation, but I don't think that's really gone, entered into this realm just yet.
Yeah, and maybe Carolyn, you might want to jump in on this one, but do you know who is doing research around this? Obviously, Neurocrine has seen the real need here and is stepping in to try to help find a potential solution. But is there a lot of research happening around this? Is there an active community?
Well, I'm sure Rob could speak to this as well, but there is certainly, there is a pediatric epilepsy research consortium in the United States mainly. There's also European groups that are doing research as well. But within that consortium, there is a specific working group that's focused on ESES. I'm not aware of any other pharmaceutical companies that are involved in specifically in this research. And to the earlier point, there's kind of some investigator studies of TMS, but there definitely is a need for more activity in this area. But Boston Children's has done quite a bit.
Additional thoughts, Rob?
Yeah, there's bring clobazam to two separate steroid trials, two different steroid regimens. That's one of the, that's, I mean, it's a very fascinating trial, but beyond that, it's a collection of a few organizations and physicians in interest. So I am part of the Pediatric Epilepsy Research Consortium, and there is a specific ESES subgroup that we're a part of, and we try to, because these are, if you look at a single institution, they may have 1 to 5 patients typically at any given time. So trying to collate that information to something that's meaningful, where you actually have real numbers and really glean information, it takes much more of a village.
Yeah, and in terms, there's a lot of questions about permanent damage and whether there will be recovery, or if people outgrow ESES. What do you have to say about that?
It's a really good one. The historical evidence has said that the longer that ESES is there, and if it's been resistant to treatment, or it's been 7 years of clinical symptoms, but someone finally does an EEG and it's there, the likelihood of perhaps the improvement when you do try to treat it, or when it does go away, that the likelihood of them bouncing back to them like their prior selves is probably not there. But it's one of the challenges that, it somewhat relates to the question of, these are not clinical seizures. And so like, even though this is going on for, patients, kid sleeps for 10 hours and this is happening for 10 hours, this is not like true status epilepticus. A patient is truly having like clinical status epilepticus for 10 hours. You see changes to the brain, you see injury to the brain. So it's strange and different. There's a different network, but that's where I think that's kind of one of the reasons why the ESES moniker is not great, because it says status epilepticus. It kind of looks like it on the EEG, but the clinical manifestations are just different.
Mm-hmm. Yeah, and that's one of the other questions that came up about, is this truly seizure activity? So thank you for answering that. That's really terrific. And I saw that you also answered a question about treating the EEG or the ESES, so people can refer there. I think there were a couple questions around that. I'm going to go, I see a couple of hands up. Oops. So let's see. All right, so Maria, I'm going to unmute. Oh, where did you just go? Disappeared on my list. Okay. Sorry, it just disappeared on me. If you still want to ask a question, put your hand back up. Thanks. So in the meantime, I'm going to move over here and look. So another one of the things that came up is what's the prevalence, incidence? Do we have any sense of how many kids actually have this? And, I mean, Leah and I were talking the other day, how many just have never had it diagnosed? I mean, it's not a very well-known syndrome or.
Yeah, I think there are probably papers that try to describe it. I mean, it tends to get this rather unsatisfying, like it's probably going to be given like the sort of, it's uncommon, but some of that's 1 in 100 versus 1 in a million. There's a lot of space in there. And I think the notion that the historical basis of using 85% and maybe moving the goalpost a little bit further down to be more inclusive, does that actually increase the catchment of patients? I think it's important, and this is always the question of, when we do find that spike wave index that is elevated in sleep, what are the clinical manifestations? And can we feel with some degree of confidence, like, yes, that is something that we can say is the ESES, and that's something we need to tackle.
Yeah. So Carolyn, there are a number of questions coming up about the status of the trial, when there might be expectations of it being available on the market, or I think some general questions about kind of timeline. Mm-hmm.
So we're in very early stages of the clinical part, meaning this is the first time that we are testing the compound in children who have this condition. So we're really trying to learn from this trial. And we are actively enrolling. Our goal is to get 24 patients. So it's going to be small since it's a rare condition. And the kind of how the process goes and how long it takes is really dependent upon this first step. So it's kind of hard to project out. But our hope is that we can enroll in this trial and learn a lot from it in order to move to the next phase.
Yeah, and something I meant to mention earlier at the start of this is just that it's important that families recognize that clinical development of drugs is a long process. It's very regulated by the FDA, and there's a lot of ins and outs. So, I mean, you could see in these timelines, right? It takes years. But if people want to learn more about that, you know, we have some webinars in our resource center. I will put the link in the chat if people want to learn more about how long that kind of process takes. So, Leah, I want to ask you something. People are asking, you know, will our neurologist catch this? Should you see somebody who knows ESES? Should it be an epileptologist? And Rob, I'm going to come to you after, but I want to hear from a family perspective about what you've seen, because you guys have been through a lot.
Yeah, thank you for asking that. It's actually a really good question. So every single time we're in the hospital, they say the same thing. You can ask 10 neurologists or epileptologists the same question, and you're going to get 11 answers. And it seems to be true. It goes back to, you have to be your own kid's champion, and you have to know as much as you can, and be as educated as you possibly can about this, and know what you'd like to try next, so you could be an active part of the solution. I personally would definitely see an epileptologist if it's possible, over a pediatric neurologist. Even though they both probably have a ton of experience, I think that ESES is definitely better handled by an eleptologist, and a large pediatric hospital you'd have the best success at. As far as a list of doctors, I mean, I don't know if I could get that. I could try.
Yeah, I could think of, you know, I have to look at who is, like, I think going, you know, with the bias, because I've trained at and I currently am at a large academic institution, yes, there's probably some more wherewithal and acknowledgement of ESES, but there are superb and fantastic physicians at smaller institutions who are more than capable of managing these things. But I think it is that conversation. And I mean, I can kind of look at the list of individuals at the ESES subgroup of PERC. But again, it is a small show, kind of like that research kind of interest in.
Thanks. All right. So, Kimberly, I'm going to unmute you if you want to ask your question. All right, Kimberly, you're still muted. If you want to unmute and ask your question, feel free. Otherwise, we can answer in the chat. Okay, that doesn't seem to be working. So I'm gonna. Okay, so let's move on then to one of the interesting things that I think came up, and probably a lot of families are curious about, is SUDEP. What's that? Does this increase the risk?
Yeah.
Evidence.
So I'll at least say there's nothing, at least from what I've seen, there's nothing that specifically says that ESES is a specific risk factor for SUDEP, sudden unexplained death in epilepsy. And I mean, at the very least, as we kind of are building up more and more of our understanding of SUDEP, again, we still see that there's a higher risk factor in adults, which is where ESES is not rather prevalent. So it seems that where, even though we have ESES more commonly in childhood, it's definitely rare enough and like perhaps not a big enough signal to change those numbers too much. And I think, you know, at the very least, our goal for trying to prevent SUDEP, it's really about managing clinical seizures, and particularly nocturnal seizures, and you know, taking medications as instructed. Those are kind of like the best things that we can do, on top of maybe growing information about nocturnal monitoring devices and things.
Mm-hmm. Yeah. And Leah, I'm going to move to you for this one, but and hopefully people don't mind sticking around for a few more minutes because this is a hot topic, lots of questions. So what do you, someone was asking about how do we increase awareness about ESES? How do we make sure that more neurologists know about it? How do we make sure that our communities know about it? You're a real advocate for this. So can you talk a little bit about how you do that in your community?
Well, sure. When diagnosed with a rare genetic disease, there was really nothing going on in. I don't know. I think we're going to need some leaders in the patient world. And I'm happy to be part of it, but I think just continuous getting there as much as possible is what I can see right now. We organize ourselves in a normal way, which I'm not volunteering to do right now.
No, you've got enough on your plate. And Carolyn, we know that Neurocrine has a strong interest in rare epilepsies. Can you talk a little bit about how you see if there is a clear link between epilepsy and ESES that you saw and therefore decided to act on?
So, I mean, I can't necessarily speak to the kind of initial impetus because like I mentioned earlier, this compound in particular was licensed from Idorsia, but certainly there is that kind of mechanistic story that using a calcium channel inhibitor, Rob can also speak just that of centers and their seizure conditions to not all of them do, or their seizures might be under control, but the children still might have the ESES pattern. So there's certainly overlap and a connection between the two, but it's not exclusive, if that makes sense.
Anything you want to add, Rob?
I don't think. I think that was good.
Yeah. I mean, and one of the other questions that was coming up too is can ESES be triggered by something, by a concussion, is there a sense of why ESES develops?
I was just about to, so I've been like feverishly typing answers just so that I can get to some of them. That was when I was about to type answer. At the very least, I don't think there's been any evidence about, and I'll kind of just extend that towards the evidence about traumatic brain injury. Typically for severe traumatic brain injury, that is not a phenotype that we see. We can see acute seizures often in the first 2 weeks, but long-term management, we really don't. So I don't think I have seen anything about that.
And a few questions or comments came in about CBN oil. Have you seen any research around that being used to stop ESES?
So CBD oil.
In here, I don't know if that's, but I assume it's CBD. Yeah.
Yeah, I would assume CBD. So there is no evidence, although there are researchers, like there are folks who are using it kind of empirically, especially if things haven't worked. And there is a trial that a epilepsy doctor up in New York, Sanjeev Kathari, he is enrolling patients in an Epidiolex trial for ESES. I don't know how broad of a catchment he's permitted from his location, but and I think the overall plan for collection for the the recruitment is, I'm not thinking he's expecting large numbers, because it's hard to find patients, and especially if you have to try with trials trying to be reasonably restrictive, so that you it can be tough. But so there's no formal evidence, but maybe there'll be something that comes out of that trial.
So Carolyn, there was a question for a clarification about selection criteria that that there were no underlying condition. Can you just clarify what that means, what qualifies?
Sure. So I think that the main thing I want to say is that if your child meets the kind of criteria for CSWS, that it's a real conversation with the physician who's the kind of study investigator, and really with their help teasing apart whether the symptoms that seem to be associated with ESES are really associated with it. Now, Rob talked about how challenging it can be to tease those things apart. Some of it is really looking at the timing of onset of certain symptoms, and if they seem to be kind of around the same time that one would think the ESES pattern emerged, then they would qualify. If a lot of the symptomatology seems to be due to the underlying neurological condition, then potentially they wouldn't qualify. But it really is an individual discussion with the physician.
Yeah, and people are asking, do I qualify? Is it happening here? Is it happening there? So I will put the link for the Steamboat study information in the chat so people can check it out and see if, and I don't think people can travel, right? So if there's a trial in Philly, but you live in Maine, if you want to make that trip. Yeah. Yeah.
And we currently have, if you go on to clinicaltrials.gov website, there's 2 sites that are listed there, 2 cities, I think it shows. We are continuing up new sites across the US and abroad. But if you go onto the Steamboat study website and fill out their kind of pre-screener information, if your child seems like they would pass that, then even if there's not a site in your area, they might refer you to one open site or kind of hold if they think the site nearby is opening up soon.
Mm-hmm. Terrific. I know that this is going quite long. I'm gonna ask one last thing, and then I think maybe what we can do is try to make sure that we get answers to these questions that have not yet been addressed, and we can post the Q&A onto the site anonymized so that people can reflect on the answers that have come up here. So I think that there were a couple of people asking about autism connections and, like, is there any clear connection, any types of therapies like, ABA that somehow can potentially help?
Yeah, I think in the situations where a patient has ESES, has clinical features of behavioral dysregulation, hyperactivity, absolute, and frank autistic regression, it does take a village, and that may involve beyond just the epilepsy specialist, because I'm by no means a behavioral specialist, to do something. There are children who may need the assistance of a behavioral neurologist or psychiatrist to help with particular medications, because sometimes these behaviors can be rather difficult for families to tolerate, and children may demonstrate self-injurious behaviors, so it can take a lot of folks. So ABA therapy and kind of, and I would probably try to go for an all hands on deck approach with like whomever you can get is probably going to be more helpful than not.
Mm-hmm.
I think within the pandemic, you know, mental health services, which I'll just kind of throw into therapy, you know, they've been overworked and stretched. So and get as support as possible is going to be key.
Terrific. And there was one, but before we close, I want to also just make sure that there's some clarity for families. Everybody is, you know, looking for answers, we know, and desperate for help to manage the many different things that we all deal with. But in terms of the access to meds after the trial, Leah, I can't find the question now, but what was it that the exact question about that?
I believe it was around, you know, if they do participate in the trial and it does work for their child, then the trial ends. It would be pretty disappointing not to be able to access the drug anymore. I'm sure there's been some thought into that, and I'm sure I'll let Carolyn answer it.
Sure, we're currently working on establishing what we call an open label extension study. So anybody who completes the double-blind trial would potentially be qualified to enroll in an extension study.
Great, thank you so much. So lots of questions coming in. So clearly this is a topic, you know, that there's not a ton of information about out there. I know that Leah is a member of a Facebook community, if people are interested in that, and as a place to get some additional feedback. And we will, as I mentioned, post these answers online. So I apologize that the speaking feature didn't work. That was new to me. So hopefully in the future we can figure that out. So for now, I just want to end by thanking our panelists and for joining us and sharing their experiences and their expertise. And we do have some additional webinars coming up. So please be sure to check out. I'm going to put it right here in the chat. And we hope that this was really helpful and that in the future there will be more that we learn about ESES. And, you know, Carolyn will definitely have you back when you learn more from the trials, hopefully. And Rob, you are very on top of the research, so we'll have you back as well. And Leah, you know, we want to keep updated on how Ben's doing and how things come together. So, you know, thank you all for joining us. I know that this is a really difficult topic, but hopefully there's a little bit more clarity today, and we will we'll keep talking about it here. Thanks, everybody.
Thanks so much. Bye.